some of the slides, has been some really excellent materials that kind of cover the handling the virus generally, what the virus is, as well as the experience from the homeless hostel side of things. So, title of our session today: Homeless Hostels and COVID-19, supporting homeless hostels in responding to coronavirus. We've got a great panel who I'm going to introduce you to in just a moment. My name's James Thornton. I'm the Senior Communications Manager at the Healthy London Partnership. Glad to be supporting homeless health through the most difficult of times. We will be having a panel Q&A, so do add any questions you've got using the chat box. There's a lot of you, which is great, but if you did particularly want to come on camera, put that in the chat as well. And again, we'll pick that up towards the end. There is a lot to get through, and as I say, you'll be able to see it afterwards, so you can pause and re-look at some of the slides in more detail. A final call just to keep yourself on mute, please, and turn your cameras off unless you are specifically on. What I'll now do is I'm going to hand across to, we've got a great panel of presenters. I'll get them to introduce themselves and I'll turn my own camera off so you can see who they are. So panel, can I ask to start with Caroline maybe?
Hello, yes, so I'm Caroline Schulman. I'm a GP. I've worked in homeless and inclusion health for around 12 years, and as part of, as a specialist in a specialist practice, but also in a hospital homeless team. But I've also done quite a lot of work working with people in hostels and trying to get integrated multidisciplinary work in hostels with some research I've done in UCL on palliative care and homelessness and with Pathway and Mungo's. And I've been involved in the Pan-London approach as well to homelessness.
Alex Manasser
is now joining.
Our next presenter, who we've got going after Caroline today?
Nalini?
I think actually it's me after Caroline. So I'm Katie Hunter. I'm a public health consultant at the Greater London Authority. And I've also been in the last just over a month working very closely with the LCRC, so that's Public Health England's London Coronavirus Response Cell, and particularly picking up some of the queries about settings such as hostels regarding COVID.
Excellent stuff. And hanging across after Katie, is that Nalini that's joining us?
Hi, yes, hello, my name is Nalini. I'm one of the consultants in Public Health England in health protection. And I work at the London Coronavirus Cell as a consultant, and I'm working with Katie on response to outbreaks in homeless settings.
Excellent stuff. And completing our panel, I think joining us by phone, is that another Katie there?
Yes, I'm Katie Davis and I'm contract manager at Look Ahead. I'm managing a complex needs hostel in Tower Hamlets for 88 residents.
Great stuff. So thank you, Katie, for giving us the on the ground experience there as well. Okay, panel, I'll hand back to you, Caroline, to kick us off with the slides.
Brilliant. Thanks very much, James. So if we can have the slides up. So today we're going to really be looking at COVID and homeless hostels and seeing, can we have the next slide, please? And the next one. Thank you. So we're going to be really looking a little bit of background on COVID, talking about routes of transmission and spread, but also just go through a little bit about vulnerability of the homeless population, which you're all incredibly familiar with, but just to really summarise how that's led to and contributed to the actual Pan-London approach to COVID within this population. We also got some guides as to what you can do if somebody is symptomatic in your service, and we'll be sharing some of the early findings from the UCL Collaborative Centre for Inclusion Health Survey, which many of you are involved with, and that is a route into getting people who are symptomatic screened as well. But we're hoping to leave some time as well to really share your experiences at the end with a Q&A. So do please on the way also write any of your questions or comments or things that you would like to share. Next slide, please. So just really overview, if the virus is a sort of coronavirus, a pretty picture, which I think we've seen lots of times on the news, and is mainly a virus that is associated with lung and respiratory disease. And the current actual coronavirus is a SARS SARS type virus. So if you could, next slide, please. Many of these slides I'm going to go through really very quickly, and you'll have access to them afterwards. As I think most of you know, I mean, COVID-19 is the name of the actual disease, and the main problems it's causing is upper respiratory tract problems and lower respiratory tract complications. So often presents with a persistent cough and a fever, but there are other signs as well, such as sore throat, changes in taste and smell, and fatigue, shortness of breath can be often a sign when things are getting worse as well. And next slide, please. Transmission, you'll hear much more from the public health colleagues on the line, is mainly through transmission is by droplet and contamination and contact with contaminated surfaces. But in fact, most body fluids can actually do contain the virus and can transmit that way. Next, please. Again, I think most people are aware that you can actually the virus can be transmitted before actually the first sign of illness. There's usually a sort of 5 to 6 days incubation period, and then that's one of the ways that the virus is managing to spread, because people don't know they've actually got it. And the infectious period is usually around 7 days. And recovery time can be a lot longer. So people often, the second week can be when people start really deteriorating, and that can be when lots of the complications in chest complications, particularly in people who have underlying vulnerabilities, that's when they can present and get quite unwell. But for many people, the respiratory systems can last considerably longer than the time of infectiousness. So people can continue to have really quite a lot of breathlessness and coughing when they are no longer actually infectious, but still need close monitoring. Next slide, please. So really, the challenge we have is that COVID, as we all know, is spreading, and London is it's been spreading quite quickly in London. The homeless population are particularly vulnerable, and I'm going to just share a little bit about that vulnerability in the next couple of slides. So in lots of ways, hostels have got very similar risks as to nursing homes, in that you often have many people with a lot of underlying clinical vulnerability in a situation where it can be quite difficult to self-isolate. And we know that hostel staff are working often under incredibly challenging situations with people with very multiple and complex needs. Next slide. And that's sort of one of the reasons we really wanted to do this, was to share, in fact, what most of you are doing incredibly well, and to just, this is an opportunity for everyone to learn from each other and hear what others are doing in this complex time. So I think everyone, again, is really aware of the complexity of need. There's often what we often refer to as trimorbidity, but it's actually multimorbidity, really. And people often have a combination of substance use issues, mental health difficulties, and often very, very profound physical health problems. We've done a lot of work which shows that the onset of functional impairment can be up to 30 years younger than for the rest of the population, with a really high prevalence of multiple conditions at the same time, but a higher risk of lung disease and heart disease. Next slide. As you can see in this next slide, again, the red shows homelessness compared with other, the dark blue is people in multiple deprived populations. Homeless, as you can see, is like a cliff edge, as people often refer to, where you have such much higher risk of asthma, chronic obstructive pulmonary disease, or other respiratory disease, chronic respiratory disease, epilepsy and heart disease. Next slide, please. So due to this vulnerability, there's obviously a real need for people to social distance. And so the pan-London approach, in fact, there's more or less a pan-UK approach, has been to try and reduce shared spaces and support people into accommodation where they can be able to self-isolate or at least social distance. So there's closure of the winter night shelters, rough sleepers have been moved into accommodation, and there's been support with hospital discharges as well. And these COVID facilities have been set up in hotels. And in addition, there needs to be this additional support for hostels. Next slide, please. So We hear a lot about shielding, so there are government guidelines as to who should be shielded, meaning that these are people who have been identified usually through primary care as being extremely vulnerable, people who really then should be completely self-isolating, have food brought to them, be not going out and really only having very, very minimal contact with people. And this is generally people who've had cancers, have treatment for that, weak immune systems, people who are pregnant, but also people with severe lung disease. And I think there's many of our population are not actually in the category for shielding, though they should be. And that's often because they may not have been identified as such by their GPs if they're, for example, not engaging with general practice and not on the medication that would define somebody to be put into this category. Next slide, please. However, we are dealing with people who often actually are as unwell as people who are in the shielding category. And so because of this, there's been another way of actually supporting people and defining when people have this additional vulnerability. And this has been particular for the homeless population, thought to include probably 30 to 40% of the population. And in this, people are being defined as being vulnerable if they're over the age of 55, because we know there is early onset aging, whether they would normally be offered a flu vaccine, but also if they have any other chronic illnesses such as lung disease, heart disease, kidney disease, liver disease, and so on. And with that, with those risk factors, we'd say that they are actually a vulnerable population. Next slide.
Samantha Mobbs is now exiting.
And this then helps put people in. This has basically been used to triage people into the different hotels at the moment. So at the moment there's been cohorting of putting people into the middle one is the yellow, which says COVID Protect. And that's where it's been recognised that people who have that underlying vulnerability need to really be able to self-isolate, to be in self-contained accommodation, and that was the priority for getting people into hotels off the street and out of shared spaces. People who are symptomatic, there is a COVID care facility, and people who are asymptomatic and also not in one of those high-risk groups, there's a range of other accommodation. Many of those are actually in different hotels as well in London. Next slide, please. So in terms of hostels, obviously you're dealing with very vulnerable people, and so we're going to go through issues relating to infection control, daily symptom check-ins, which are really are very valuable in identifying people as soon as they are symptomatic, and enabling them to isolate, but also enabling them to get screened and tested, which I'll talk about later as well. I'll also talk about the referral into COVID care potentially, but mainly about symptom screening and then screening, and then testing, and then moving into COVID care.
Is now joining.
But I think one thing that really to say is there haven't been any major outbreaks in the hostels so far compared with care homes. So I think this is absolutely fantastic. But there really does need to be ongoing vigilance and surveillance, because we know that as soon as lockdown is down, people who are vulnerable are at high risk of still getting infected. And with this vulnerability, they are at higher risk of getting very sick with that. Next slide, please. So I'm now going to hand over to my public health colleagues. So Katie, I believe first, and then Nalini. Thank you.
Thanks, Caroline. So yeah, I'm Katie Hunter, public health consultant at the GLA, and also working with Public Health England in the London Coronavirus Response Cell. So I just want to talk about the key elements of infection control. So this applies everywhere actually, but I mean for the hostel settings, for all of your clients and all of the staff. So I think, as we all are probably really aware, one of the key elements is the social distancing, which is keeping a minimum distance of 2 meters away from other people who, where at all possible. And then really key is frequent hand washing. And to be honest, we can't emphasize this enough. So washing hands for at least 20 seconds, so really thorough hand wash, and we'll show a slide on that shortly. And if there isn't water available, then using a hand sanitizer, an alcohol hand sanitizer instead. And essentially the reason for this is that whilst the coronavirus is transmitted sort of through droplet spread, those droplets can then contaminate other surfaces. So if you touch that contaminated surface with your hands and then touch your face, that's how you infect yourself. So it's much less likely that actually you're going to be directly sort of sneezed or coughed on, and that it's going to transmit that way. It's much more likely that it's something that you touch and then you touch your face. So that's why it's so important to avoid touching your face, nose and eyes with unwashed hands. And also why the principle of cleaning environmental cleaning is really important. So that's cleaning those kind of high touch surfaces around the hostel. For example, the door handles, the rails, any sort of surfaces like food preparation surfaces, bathroom surfaces. So those three elements, social distancing, hand hygiene and cleaning of the environment, not touching your face, are really important. Next slide, please. So as we said, staff and residents should stay 2 meters away from each other at all times. And where you can't have social distancing, those communal areas should be closed. So if it's not possible to keep people 2 meters away in communal areas, then do close those. For the canteens or the sort of food areas, obviously, people need to get their food, but you need to kind of think about for your local setting whether or not you can do alternative things such as having rotas of when people use that area, or when they come down to perhaps collect food, or can you deliver food to people's rooms, because essentially you really want the residents to be eating in their own rooms so that they're not congregating together in a communal area. And then again, this is all for people who are asymptomatic. So this is sort of the standard infection control advice in the current situation, that for bathrooms, if you can allocate people to specific bathrooms rather than that anybody can sort of use whichever bathroom they want to, then you're reducing the amount of crossover of different people sharing different spaces. And you need to obviously, I think this is pretty standard that you've probably all done already, but having no visitors to the hostels other than people that are obviously working there, and the residents, so that you're really minimising that contact. Next slide, please. So again, as I've said, the hand hygiene, really, really absolutely vital in this. And it's the, good hand washing for 20 seconds, covering the fronts and backs of the hands, all the areas, using soap and ideally hot water. But actually the soap is really crucial, because that's what actually breaks down the sort of fat layer around the outside of the virus and kills the virus. And as we've said, again, just frequently cleaning and disinfecting those regular touched areas, particularly in any kind of shared spaces that people have to walk through, or communal areas where if you are able to social distance, if they're still being used. And then increasing the frequency of anywhere like shared bathrooms as well. So it's using the normal household products that you would use, and detergent and bleach, but more frequently than usual. Next slide, please. So again, you can look at this later, the hand washing slide, but it really goes through obviously, you know, wet your hands first, then put on the soap, and then just all the different parts of your hand that actually you do need to concentrate on. I think we all kind of aware that actually in regular life we don't wash our hands like this, but actually this is what people really do need to be doing at the moment to ensure that they are really getting rid of any virus that they might have picked up on their hands. And it's particularly important, you know, if you've before or after you have any contact with other people, so any of the residents, obviously bearing in mind that ideally you should be keeping 2 meters away from residents. Obviously, if you've coughed or sneezed or, you know, had to use a tissue, you must wash your hands afterwards before you prepare food, and obviously after you've used the bathroom. There is a link to a video that we can then send you afterwards. You know, ideally, again, you know, you should be including your kind of wrists, in, you know, when you're washing. Next slide, please. And then just I'm about to hand over to Nalini, but just to say that it's actually, we know that often people don't, you know, report their symptoms straight away. They're, you know, perhaps a bit worried or reluctant to say, or they think it's kind of nothing. So we've had quite a few situations where perhaps people have been unwell for about 4 days before they've said anything to anyone. So it's really useful if you're able to ask the residents on a daily basis, you know, do they have cough or fever? Those are the 2 key symptoms that we're really concerned about. And you can do that either by ringing the room or perhaps just knocking on the door, having a conversation, you know, with them 2 meters away. And then, you know, if there are symptoms of cough or fever, then we would ask that the resident self-isolates. So I'm handing over to Nalini now for the next slides.
Thanks, Katie. To remind everyone, my name is Nalini. I'm a consultant in health protection in London, and I work at the London Coronavirus Cell. I'm going to go through the actions that we are suggesting if you have a symptomatic resident in your setting. There is no specific guidance on homeless settings at the moment. So this guidance is put together using standard, the other PHE, normal PHE guidance. And it's already, we've written FAQs, or the GLA has written FAQs that we've been involved in working on. So none of this should be new to those of you who've seen the FAQs. And it's very much, the information is very much predicated on avoiding exposure to the virus. Through isolation of cases, through isolation of contacts, through cleaning and appropriate use of PPE. So that's what I'll go through now. And when I say if someone becomes symptomatic in your setting, I mean residents. We'll get to staff later. So the very important part of this
is now joining.
One of the most important things to do is isolation of the case, and by case I mean the symptomatic resident. That's the terminology we use in health protection. And by isolation we mean that they remain in their room or their flat for 7 days from onset of symptoms and have no contact with anybody from outside. So it's not, they can't come out for meals, you can't go in and put meals in their rooms, that kind of thing. They must completely avoid contact with the outside world. I've said 7 days in my slide because that's the PHE guidance. I know that 14 days is in the FAQ, and I know places like COVID Care are using 14 days. And if that's what people are able to do, that's absolutely fine. But it's PHE guidance is at least 7 days, and until symptoms have resolved, which could be long. With 7 days, just because that's what the PHE guidance says, in lieu of any specific guidance on homeless settings. I know there are settings that have shared bathrooms, and we would suggest that cubicles are restricted to symptomatic people and that they are the last people to use them in order to avoid cross-contamination. And so in addition to the isolation of the case's contacts, because we know that there are settings in which people don't have their own room, they might be sharing the same room or a flat with others. Even if you've moved that symptomatic person out of that room or flat, the people that they've been staying with are contacts in the same way that in a home, other people that you're with are household contacts, so they should self-isolate for 14 days as well. And the principle with self-isolation for them is the same as with the case: no contact with the outside world, keep a lookout for symptoms, and if you're symptomatic, then they get treated as a symptomatic case. And just to make the point about the isolation of the case, even if they stop becoming symptomatic soon after, so if they stop becoming symptomatic on day 3, for example, the isolation should continue for a minimum of 7 or 14, if that's what you're doing, 14 days. One of the other things for a case that we like to do for cases is test, but Caroline will get to that soon, because that can be arranged via find and treat and through the survey that Caroline will talk to you about. The other thing to do with if you've got a case in your setting is cleaning, and cleaning in the environment where the suspected case has been or where the suspected case is living. And I'll go through that in a bit more detail, and I'll go through PPE use as well. So next slide, please. Okay, so in terms of cleaning, and this applies very much to settings where a symptomatic person has been. There are 2 types of cleaning, or 2 settings where you would think about cleaning. One is communal areas where if the person has been symptomatic and has been there. Now you do need to clean that as soon as possible after the symptomatic person has been, and there's PHE guidance on what disinfectant and cleaning materials to use, and the link is in the website and in the FAQ, in the presentation and in the FAQs. So any surfaces that the symptomatic person has come into contact with should be cleaned and disinfected. So this is for sort of communal areas. And then thinking about areas where cases are self-isolating because they're symptomatic, our suggestion is that staff try and avoid exposure by not cleaning the rooms where people are self-isolating. So if say somebody's self-isolating for 7 days, we suggest that room is not clean for 7 days, and then actually ideally that room is not clean for a further 3 days, that to allow the viral load in that room to go down to normal levels, and then the room can be cleaned as normal. If you absolutely have to clean whilst the person is symptomatic, then appropriate PPE must be used, and please consult the PHE guidance on what cleaning materials and disinfectant to use. For communal bathrooms, as before, the suggestion is that the person has a cubicle assigned to them so that they're not coming into contact with people who are not symptomatic. But what they should be doing after use of communal bathrooms is we would suggest that you allow them to clean the bathroom, followed by cleaning by staff using appropriate materials and PPE. If staff are cleaning, they should use PPE, gloves and apron as a minimum, but I'll go into that a bit more. And then to reiterate, if you're cleaning, particularly after in an area where a symptomatic person has been, you take off the PPE and then you wash your hands for 20 seconds at least, as Katie has gone through. Next slide. Okay, PPE. Generally, we don't expect that PPE is going to be needed in this setting because we are suggesting social distancing and suggesting isolation. That's an ideal world. I completely understand that there are going to be times when you, for whatever reason, have no choice but to come within 2 meters of somebody that you think could be symptomatic. So in that setting, you would use PPE, and I'll go through what the PPE would be. But as much as possible, we would suggest absolutely trying to avoid that. The other circumstance where you would use PPE is if somebody is extremely vulnerable, and that's Caroline went through that in one of her previous slides, and they're being shielded, then it's about you using PPE in order to protect them, not the other way around. And again, I'll go through what PPE you need to use for that. But again, I would advise try not to do that. So try not to go into the room of somebody who is shielding, to have less than 2 meters contact with them. This is a bit like somebody shielding in the community, for example. You would try absolutely not to go into their homes. So the same in a hostel setting. Next slide, please. So PPE, as a minimum, disposable apron and gloves should be used. Fluid repellent surgical mask is advised if you're going to be less than 2 meters of a case, because as Katie and Caroline were talking about before, it's droplet spread, people might be coughing, and that's what the surgical mask is protecting you against. What you mustn't do is then touch your mask and then touch your face. That's how you do self-contamination. So if you are wearing mask and PPE, you should be very careful about not touching your face. And then once you've finished whatever task it is you were doing, take it off and wash your hands very thoroughly. So it's very important that PPE, you don't feel as if you're invincible wearing PPE. Hand washing is still very, very important, and appropriate taking off and use of PPE is really important. Eye protection should be used if there's a risk of splashing or other contact with body fluids. Try and avoid that as much as possible. There are instances where it's not going to be possible to avoid, and in those settings, eye protection should be used. If you're going into the, so that's for cases, but if you're going into the room of somebody who's shielding, then the advisable PPE is apron, gloves, and a surgical mask, which could be non-fluid repellent. For that shielded group, because as I said, the idea there is that you're protecting that shielded person from you rather than protecting yourself from them, assuming they don't have any symptoms. Next slide, please. Right, waste disposal. The principle here again is to try and avoid exposure to waste from the person who's symptomatic. So if they continue to remain in your setting, what we would suggest is, whilst they're symptomatic and whilst they're self-isolating, they clean their own room and they put the rubbish that they generate in plastic rubbish bag and tie it when full, and then place it in another bag, so it's double bagged, and then they leave it in their room for at least 72 hours or until you know them to be negative. The idea of the 72 hours is to reduce the viral load to the levels where it's no longer presenting as much of an infectious risk as it was before. So they leave it in their room for 72 hours. You could then pick it up using PPE and throw it away as normal waste. If it has to be thrown away before the 72 hours, then it must be thrown away as infectious waste. And I don't think that's possible in a hostel setting, but I could be wrong. So it's important that 72 hours at least is adhered to. Okay, next one, please. For laundry generated by those who are self-isolating, it can be washed, but as before, we would suggest you try not to expose yourself to this. If you absolutely have to wash laundry of the people who are symptomatic whilst they're isolating, ask them to double bag it, pick it up using PPE, and then it should be washed at the warmest setting that's possible. It must not be, you must not shake dirty laundry, because then the virus particles get into the air, and then wash it using manufacturer's settings, but at the warmest water setting. If the laundry is soiled, then it should be disposed of with double bagging, as in the last slide, but obviously with permission from the client. And then again, wash hands afterwards with soap and water, even if you've used PPE. And if you've used something to transport the laundry to wash, then clean and disinfect anything that you've been anything that you've been using to transport it. Next slide. Okay, so having covered what you would do for symptomatic residents, for staff, I'm sure you're all aware, if you have symptoms of COVID, fever or cough, then you stay at home. This is to protect the residents that you're working with. Your isolation period is going to be 7 days, or if you continue to be symptomatic, then longer than that. And you have to be fever-free as well. So if you continue to have a fever, then you at 7 days, then you should be asking for a clinical assessment and not coming into work. Some people continue to have a cough for quite a long time. So a cough alone doesn't mean you should continue to self-isolate. You can come back to work after 7 days, but that's only if you have a cough alone. The other circumstance where staff should not come into work is if anybody in their home has COVID symptoms, and they should then observe a 14-day isolation period, and then they should look out for symptoms in themselves, and if that happens, then they self-isolate for a further 7 days. Okay, next slide. So finally, if you have cases in your setting, then Caroline will talk about the survey, the baseline survey and the daily symptom survey, which you can use to report and to get access to testing and other clinical support. We at the London Coronavirus Cell are very happy to help you with outbreaks and how to manage outbreaks. And by outbreaks, we mean 2 or more cases in the same homeless hostel setting within 14 days of each other. If that happens, you have an outbreak, which means you've had transmission from one person to another person. So when you call into us, we will give you advice. We'll give you advice on how to manage that. And if you're still not aware of how to access testing, we'll give you advice on how to access testing as well. The number there is for the London Coronavirus Cell, and we're operational from 9 to 8 p.m. on a daily basis, including Saturday and Sunday. And I think we've spoken to but we are available for advice on outbreaks if people want to call us. That's it from me.
Thank you. So next slide, please. Caroline back in here. So I'm just going to go through a little bit about the UCL Collaborative Centre for Inclusion Health Symptom Survey, which I think many, or the Survey Monkey, that many of you have actually signed up for. And go a little bit through what that's shown, and also urge those of you who haven't signed up to do it to do it actually. So there is a survey that's been set up. It's got a baseline survey, and then it's following that there's sort of daily check-in surveys, which are very, very quick to complete. The baseline only takes about 10 minutes, I think.
Is now exiting.
And then what the survey enables you to do is to actually access testing and support if you find somebody in your hostel develops symptoms, and that's basically from the Find and Treat team. The Pan London Find and Treat team will come and speak to you and then test where it's appropriate. It's also going to give us much broader surveillance, so we understand how COVID is affecting people within this community, and can enable us to raise awareness about the health needs of this group. Could you next slide, please? So if somebody is symptomatic, then you still need to kind of contact GP or 111 to get advice and to think through. Obviously, if someone's very unwell, 999, and you get somebody to self-isolate. But in addition to that, you can report the case. So using the daily symptom survey, and when you get these slides, there's actually a link to it here if you haven't already got that. And you can complete this short linked referral form, and you can complete the survey, and there's a referral form that is linked to it, which then you can complete, again, a very brief referral form just around the person who is symptomatic and when their symptoms started and what they are. And there's an email address on that form, a very, very quick referral. And then the testing team will phone, speak to the person. So it's important that you put your phone number and contact details, and then come get more detail, and where appropriate, arrange to come and do some testing. Again, depending on the situation and whether somebody is able to self-isolate or is not able to self-isolate, depending on the situation and depending on their clinical picture as well, there may be the offer of them moving for the duration of their illness into COVID care facility. There's also, if you haven't completed the baseline survey, then it's best to complete that one first, which is a 10-minute survey. But once you've completed the baseline, you can do the daily symptom survey. As has already been mentioned, if there's 2 or more symptomatic people, also refer to the LCRC as mentioned before. Next slide, please. So yes, I just should stress, I saw there's a comment. This is, at the moment, this is a London-wide survey, and it's for London hostels, and the survey and the symptom management and the screening is London at the moment. So just a little bit about the findings, the baseline. So 120 hostels have responded, which is fantastic. Anyone who hasn't, shout out there to you to please do it. It's not a long survey, and it's incredibly useful. Not only it's useful in terms of the data, that it's the rich data it's giving, but more importantly, it's for you yourselves in terms of being able to have easy access to screening, and then some other clinical advice. So the majority of people are in single rooms, but about just over half are sharing bathrooms. About a quarter of people are aged over 55, so in that vulnerable category. 28% have chronic conditions, and 60% problematic drug and alcohol use. Next slide, please. Thank you. So just very briefly, some of the findings. At baseline, from the people who've completed it, there were actually 3 deaths reported, but it's not clear whether they were COVID-related deaths or not. So we don't have any more information on those. 11 people have been hospitalised with COVID-related symptoms. This was at the time of the baseline being completed, and there were 25 symptomatic reports in the previous 14 days. Now, actually, the number of symptomatic cases is only around 1% of the population, so it's actually quite low, and it may be that there's under-identification. Then for the people who've done the follow-up surveys, again, there have been around 20 residents and 7 reported cases in staff. But these are preliminary findings and unpublished, and I can't twin that with the results at the moment. Of who was positive and who wasn't, but I believe there have been 26 positive cases. Next slide, please. So only 30 hostels, I think, are currently signed up to do the daily reporting. We need this to increase because it really is really helpful, and it literally takes a couple of minutes. So maybe set the link on your a reminder on your computer or whatever to do that. Next slide, please. So we know it's a horrendously stressful time for absolutely everybody, and it can be really hard for you to support your residents to self-isolate, particularly with people with substance use issues and mental health difficulties and staff shortages, which are often in place. But despite that, there have been some incredibly, I'm going to share now a lot of the good practice, the last couple of slides. Next slide, please. Which again, from the survey, we've seen that you're doing some fantastic things out there, really. And I thought this would be really helpful to share so everyone can learn from each other, really, in terms of what information we've been getting from the survey. So basically, around half of you have closed your communal areas, and that's involved taking meals into rooms, using disposable containers from the canteen. One hostel had secured meal boxes from a charity. Many of you are limiting the use of communal areas by creating rotas, marking 2 meters on the floor. So all fantastic practice. Other ways of supporting people to remain in their rooms are, again, taking meals and prescriptions to rooms, particularly for the very vulnerable, providing televisions and other appliances, such as I think there was microwave or kettles, mobile phones, phone credit, delivering food, and alcohol. Again, a real shout out to alcohol. As I think all of you are very aware, if somebody's alcohol dependent, they cannot stop drinking, because that's incredibly dangerous. So having some policy around what you do around supporting people who are alcohol dependent and actually giving them buying alcohol either with their money or a fund to ensure that while they're having to self-isolate, they are able to actually get alcohol. I think many of you have actually asked residents what they need to allow them to self-isolate effectively, and somehow trying to meet that support. I think you're all preventing visitors mainly, and reducing interaction between staff and residents. So a lot more interaction taking place by phone. Next slide, please. In terms of infection control, you mostly mentioned giving information around hand hygiene and infection control. Many of you had posters up giving information about COVID, and most of you were doing some additional cleaning of shared spaces, such as hard surfaces, door handles, lift buttons, and so on. Some of you mentioned the bathroom cleaning, but I don't think large numbers. But again, I'm not sure on the actual numbers there. Many of you had given soap and sanitizer to residents to help them, and had some hand sanitizer on the door. So I think, you know, some fantastic work going on, and I'm just going to I'm going to hand over. We're going to be going into questions, but I just wanted to hand over really now to Katie Davies, who's a manager at Look Ahead, who's going to be on the panel, and just to share some of her experiences, and then we can move over to some of the questions. Thank you.
Thank you. Yes, so I'm Katie Davis and I'm a hostel manager at Look Ahead. I think the sharing of good practice amongst hostels is really important so that we can share our learning and our good practice. So we're following all the guidance that's already been mentioned. We also, there's the government website where if a customer has had the 12 weeks shielding letter, you can actually sign up and the customer will get extra support and food packages.
Maria is now exiting.
Are vulnerable, your local council, Tower Hamlets Council, have also got on their website where you can sign up for vulnerable customers who get food packages and extra support. So there is lots of support out there for you and for your customers as well. And I need to stress how important it is to complete the UCL Daily Symptoms survey, because it's a really good way of supporting your customers who are symptomatic to be tested. One of our customers was displaying symptoms yesterday, so we completed the UCL Daily Symptoms survey and also sent an email using the email address. And a couple of hours later, doctors came to the project and arranged testing for COVID-19 for the customer, and we will be receiving the results back today or tomorrow, so we will know if this customer has actually got a confirmed diagnosis. So it is really important to complete the survey so your customers can access the testing.
Excellent stuff. Checking that I've got myself off mute. I have. Thank you, Katie. That was a brilliant way to end what I think has been a really excellent session today. And thank you all for sticking with us. I know there's more than 120 of you out there and all managing to stick on mute, which is brilliant for Teams. We have had some questions in, so let's go through those. I think, Katie Davis, probably one for you, first of all. Stuart Hooper has asked us, any ideas or resources to help reducing social contact? Street attached community struggles with adhering to social distancing guidelines and risks spreading the virus. Any insights or thoughts or experiences to share? Katie, perhaps you could go first.
So we followed a lot of the guidelines with the hostel in that external visitors are banned. So visitors aren't permitted to come into the hostel apart from carers or medical staff. We also are contacting customers a lot more by telephone or through their doors, knocking doors to do welfare checks. And it's important to do the daily screening, asking customers how they are, if they're displaying any symptoms. And it's reminding customers about social distancing, the need to stay in. I do understand it can be a bit difficult for some customers to follow the guidelines if they don't have full capacity, but it's just trying to remind the customers that they need to follow these practices to keep themselves safe and to keep others safe.
Brilliant. Thank you, Katie. Any other members of the panel want to come in, or shall I move across to the next question? All quiet. I'll move across to the next.
Just wanted to say, so it's Katie Hunter here. I know, I mean, there probably aren't that many hostels that are fortunate enough to have gardens, for example, but I think there are a few places that do have, and obviously just maybe thinking about things about, can you adjust any seating that's in the garden so that actually it places people further apart than it would do usually. And I think, again, where you do have communal areas open, can you just move the chairs so that they are 2 meters apart so that you're not encouraging people to sit together?
Excellent. Thanks, Katie. First question we had in this afternoon was from Sharon Collins. Thank you, Sharon. She's asking the panel, good afternoon. I understand NHS England has written to GPs about local coordination of healthcare for homeless communities. Is anyone cited on the guidance and what hostels might expect in terms of healthcare support at primary level, please? Is this one we can pick up, Caroline, do you think? Or is this one for later that we could come back on?
This might be one we come back on later. I know that certainly, I think you're all aware that everyone has a right to register with a GP, and this is absolutely right. I was involved with a webinar for primary care for GPs just this last week, actually, with the lead for NHS England on homelessness, and we certainly made it really, really clear that GPs had a place in supporting hostels, in helping to identify who is vulnerable, to help hostel staff in ensuring that they were getting the support that actually we're trying to share on this webinar. But I don't know of any other letter, but I have actually, since seeing that question, I have actually texted my contact at NHS England and trying to get an answer to you as to if that letter's gone, what the content of that letter might be, and then we can share it when I get it. Thanks.
Brilliant stuff. Maybe we can we'll see whether that's shared direct or whether we can get that out with the recording, which we'll share afterwards as well.
Sorry, just coming in, I've had a reply.
There we go.
She said it will be in the GP SOP, due to be published imminently. So not seen it. So there, how did you know? That's amazing. You clearly in the know there, Sharon. Thanks.
Fantastic. Well, that sounds like it's all working rather quickly, as does the survey. It was good to hear Katie Davies' experience on that and the reactions to it. Segue neatly then, we have a question from Tracy. Tracy's asked, says that she manages hostels for homeless families. So are the surveys only aimed at single homeless clients? Is that one for you, Caroline?
Yes, again, I think currently they are, but I think, again, let's take this back to the group. I think at the moment they have been. Again, I was just in contact with Miriam Bullock, who's working with Andrew Hayward, our story, on collecting and collating all of this information. And at the moment it has been the single persons hostels, mainly because also the COVID care and the COVID Protect hotels, which they're linked with, have been for people who are single homeless. But again, this is potentially a gap which we will take back and discuss. So perhaps, yes, we can take your details and look into that as well. Thanks very much for the question.
That's brilliant. The final question I can see, although I will double check in the chat box in a moment. Felicity Owen, thank you. Felicity is asking, what process do we have in London for capturing and sharing good practice? Before I put this to the panel, we are running a page on the Healthy London Partnership, which I'll just put the URL to in the chat box now. Where we're trying to capture as much of the kind of guidance and case studies and things are starting to form up as well. But was there anything wider than that that the panel wanted to add in terms of capturing and sharing good practice? Well,
no, not that I know of. I don't know. I think it's a really, really important and good idea. So
yeah, I think that, and I think just sharing on behalf of the Healthy London Partnership, we're leading the kind of the operations team, I think is the colloquial way to put it, in terms of responding to COVID, supported by many, many, many partners, not least those on the call. And we're using that URL as our kind of base for gathering things. It feels to me like we're slightly moving into a next stage, and so I think we're starting to see more experiences as opposed to just sharing guidance and policy, if that's the right phrase. Okay, I think that covers all our questions for the day. Is there anything else we want to hear from the panel before we start to wrap up? Okay. No more questions from the chat box, so I'll just take a moment then to thank everyone on the panel. It's been a really, really insightful afternoon. We will share the recording afterwards with you. Please share with colleagues if you can, and on that we'll also include all the contact details that we can as well, so you've got those as well as those shared in the presentation. Thank you for everything this afternoon. Bid you goodbye and all the very best.
Thank you very much.
Thank you.
Thank you.
Can I ask a question?
Oh, yeah.
Yeah. Is it possible to have some...
To introduce yourself, sir, sorry.
Sorry, I do apologize. So my name is Mr. Hassan Ahmed. I'm social prescriber, link worker in Southwark. So we are supporting the community in this difficult time to, in terms of medication and, you know, keeping well, mental health. So it would be really nice if I could have some the slides so I can share with my team, because they also are supporting the community, and lots of interesting information was in that slide. And I would really appreciate if I can have a copy of that slide, please.
Great. And as well as the recording, I think if the
yes,
panel,
I'm recording as well.
I think we'll share the recording and the slide deck, as you say, so that you'll have both in 2 different versions. So I think we'll make sure we do that. Okay, everyone.
Thank you.
Thank you very much. I'll speak to you again soon.
Thank you.
Thank you.
Thanks.